Hey Jordan, love you. Finally doing them. Sorry.
Alright, you respond to a 54-year-old male that was involved in a motorcycle versus car accident.
Okay. 54-year-old male, motorcycle versus car. We're going en route. I'm assuming PD's either there or on their way.
He's there.
PD's there. Do we know who my patient is?
Yes, en route you hear that there's a doctor on scene and CPR is in progress.
Cool. Okay, so we'll roll up on scene. What's like my general kind of impression?
So you are off the side of a road. We'll say Yellowstone Highway.
Okay.
You have a swarm of people around a doctor or a lady that appears to be a doctor doing compressions on a man that's laying on the ground.
Okay. So is like traffic blocked off and stuff. Are we safe?
Yes.
Okay. So then I have my full protective equipment. So they're doing CPR on that person right now.
Mm-hmm.
I'm going to then do a quick kind of 360 of the scene. I'm looking for any other patients.
Okay.
Do I find anybody else?
No other patients.
No other
Guy
patients.
says, screaming in the side, saying, "I hit him. I'm so sorry. I'm so sorry."
Okay. And so this is our one patient. That's the only one that we have to worry about. So we're doing CPR on scene. We're gonna have him stop that for a second. We're gonna feel for a pulse.
No pulse.
No pulse. Okay, so we're gonna have whoever the heck is doing CPR right now. They can keep doing CPR. We're gonna get initial ventilations. We're gonna want to get Lucas. We're also gonna look. Is there any like major, massive bleeding coming from this person?
No major, massive bleeding. Just some abrasions to the face. Some blood coming out of his mouth, but
Okay, sounds good. And you said there's a huge wad of people around.
yeah.
Okay. So I'm going to want to get Lucas on this person. And then once we get Lucas on this person, I want to get a board underneath them. And then we're just going to pick him up and put him on the cot. And we're just going to get him into the back of the ambulance because we don't need all the people on there because they aren't going to do us any good.
Cool.
So we got him in the back of the ambulance. So there's somebody doing respiratory ventilations. We're doing 30 to 2 right now with Lucas on. We'll just start running down cardiac arrest. So we want to get our pads on. Once we get our pads on, we're also going to be trying to, hopefully, from this doctor, I don't know if they're actually a doctor or not, but I want to figure out what exactly happened, what exactly they saw.
So they were just a person driving behind and saw it happen. Car swerved into the lane of the motorcycle, clipped him, motorcycle flew off the side of the road.
Okay.
That's where he's at, or that's where he was.
Sounds good. Okay, so we got compressions going, we're doing ventilations. We're going to get, if our pads are on there, then we're going to pause compressions and we want to get a rhythm analysis going on. So we're going to feel for a pulse. We're going to check for the rhythm.
No pulse, you see VFib.
VFib. So we'll shock at 200 joules.
Cool.
And then immediately start compressions. And hopefully we have an extra person to kind of work as a timer. If not, we have the clock in the back of the ambulance. We're kind of going to be running off of that. So we'll make a note of that. We'll be doing pulse checks every 2 minutes. We're going to want to get access in this person. So IV or IO, whoever's in charge of that. Doesn't really matter if we have a paramedic. Whatever they feel like they can get. So we'll want to get that and we'll want to get 1 milligram, 1 to 10,000 epi rolling in. We'll get that every 3 to 5 minutes. We can also get a bag of just fluid hanging right on that as well. Once we hit our next pulse check, we'll pre-charge the monitor up to 300 joules this time. We'll pause Lucas, hit a rhythm check, feel for a pulse.
Asystole.
Asystole. Can't shock that, so we'll dump the charge, keep going. So we'll be going, we'll get and keep rocking our epi when the time comes. We can start prepping for an advanced airway. And so we'll intubate once we do that. And we have confirmed location with end tidal, with bilateral lung sounds, chest rise and fall, and no epigastric sounds. Then we can switch Lucas over to continuous mode, and we just start going to town there. We'll keep giving our epi every 3 to 5 minutes, pulse checks every 2 minutes, as we're going through, we're gonna start working through all of our different H's and T's as well if we haven't gotten a pulse back. So come next pulse check, pause and Lucas. I guess we'd be ventilating every 6 seconds as well at this point too. Not the 30 to 2. So you can pause Lucas, feel for a pulse, any pulse.
No pulse. But when you went and you listened to lung sounds after you got the tube, you realized that there was on the left side.
Okay.
I mean, once you could see a bunch of crepitus, you felt for the crepitus, and there was not really any lung sounds there.
Okay, so we have lung sounds on the right side.
Yeah.
We have major injury on the left side and absent lung sounds. Given the mechanism of injury, traumatic arrest, very high likelihood of pneumo going on. So we can take a needle decompression dart. You can stay in the second intercostal space. Hopefully.
Cool.
And then we can kind of keep reevaluating, seeing how that goes. Just keep rocking the code, see if we get
Are you transporting or are you on scene still?
I'm still on scene.
Okay.
When it comes down to it, I think traumatic codes are very not usually super good outcomes. And so I say, let's just stay here. Let's not risk trying to do our job hauling down the highway in the back of an ambulance.
Cool.
For something that's probably not going to get fixed. Yes, traumatic injury. Yes, ERMEC is the trauma center. But right now, they don't have a heart that's working. And there's a lot more things going wrong that I don't think they can fix at the moment. So we'll just keep rolling through that for a while. I guess after a couple more pulse checks,
He's dead.
still dead. DED, mega deado.
Mm-hmm.
So we'd call up the hospital.
All right, let's hear it.
Call them up, Madison. So hey, this is Josh with Madison Ambulance. I have a patient report and I need to speak to the doctor about a code. So we get transferred over to the code.
It's Dr. Wells.
Dr. Eddie, what's up, my guy?
Howdy.
Okay, so we have a 20-ish-year-old male involved in a motorcycle accident, traumatic arrest. We've been doing CPR for the past 30, 40 minutes. Sure, we've been here for maybe 30 minutes. We've been here for a little bit. It was initially in VFib. We shocked once. It's been in asystole ever since. We've been given epi every 3 to 5 minutes per ACLS. We're intubated. We've been attempting to correct for our H's and T's, and we have had 0 success. We have seen no changes in title, no attempts to show that there are any signs of life, and we're looking for medical control approval to call this code.
You can
Any
call
questions?
it. Nope. You
Okay.
can call it.
Call that, so we'll mark the time of death, stop Lucas, hand it over to the PD. I don't exactly know how that works.
Yeah, how does that work?
Yeah, that's exactly how it works. So if you, especially something like that where it was like a trauma